কৌশিক রাজীব কি লগ ইন করেছে? Now we are going to resume our master class for the day. Now I request Dr. Minal Kanti Rai, who is one of our course directors, to introduce the chairperson and the subject if he thinks. Dr. Minal Rai, please.
Thank you, Dr. Amar Banerjee, for asking me to introduce our chairperson as well as a few words about the subject. Now, this is that little bit change has been taken place, as you are all aware, for last few classes. Now we have shifted to case-based discussion, and I think Dr. Banerjee and all our course coordinators, we are in the same opinion that if these types of case-based discussion is done, the PGTs will be more interested and it will come to a very good, I think, outcome so far as their practical examination is concerned. Now, you all know this plasma cell dyscrasias and or rather the plasma cell disorders are not very uncommon, constitute the incidence in around 5% of the adult population. And it forms an heterogeneous group of diseases, as you all know, and that is very much characterized by, that is your expansion of number of monoclonal bone marrow plasma cells that produce a lot of immunoglobulins. And sensitive electrophoretic methods have shown that this can be identified in most of the people. Thus, that is a major consideration, or rather important in our clinical practice when the patient presents with the typical features of bone pain, lytic lesions, the M bands, and all these things. But sometimes it poses a lot of problems. So it is sometimes very difficult to distinguish between the benign and the malignant forms. We can easily recognize that is your solitary myeloma, or you can overt myeloma, plasma cell leukemias, and this requires the chemotherapy. Now, with the advent of different types of laboratory investigations and prognostic markers, it is very prudent and also pertinent to select the groups of the patients who will be benefited by the chemotherapeutic regimes. With these few words, I think when these patients come to a physician, what a physician should do at the very beginning is to be learned. And I think Dr. Rajib Dev will highlight those points, because in most of the situation, the classical marrow picture of plasma cells, the M component, lytic bone lesions, or the beta-2 microglobulins may or may not be present. And with these things, I think a few words of introduction, I think case-based discussion will be very much beneficial. Right at this moment, I'll just like to share one of my experience. At the present moment, one of my very close known lady is admitted in one of the hospitals. She is a lady of 30 years old. This is also a case scenario, and Dr. Madhuchanda Kaur can actually highlight on this point also. I went to a place in Assam, and I find that she had a bone pain during her pregnancy, so the X-ray could not be done, but the ESR was very high. After the pregnancy is over, a female baby has been delivered 1.5 months back. After that, it was found that she had a collars fracture in the D10 level, and there was a high rise of ESR, but the peripheral blood smear did not have any type of problematic cells. However, she was brought to Calcutta, and all the investigations, relevant investigations were done, and trephine biopsy and bone marrow was done, and it was found that she was harboring a case of ALL. So this is a very atypical presentation of adult leukemia in the ALL, that is acute lymphoblastic leukemia, presenting as a bone involvement in that to start with. So there are few reported cases that can also be a presenting feature, which very much look like a multiple myeloma-like presentation, because though there was no M protein, but there was a distortions in the globulin range. So a lot of things were considered. Prognostic markers have been sent, karyotyping has been done, and patient will get the induction chemotherapy right now. Probably she might be a candidate in future for a bone marrow transplant. Anyway, with these words, I think a word of questions should be for the physicians from the hemato-oncologist, when to refer the cases, what are to be things suspected. Now, coming to the introduction of our speaker, I mean the chairperson, She is very much known to our API forum, Dr. Madhuchanda Kaur. And Madhuchanda has a very much well-known figure in the field of oncology. And presently she is attached to, you all know that she is attached to this Peerless Hospital. And she is presently the director as well as course coordinator, the Department of Oncology, Peerless Hospital and Bigala Research Center, principal investigator, ICMR Hospital-Based Cancer Registry, former chairperson, BOG, IISER Mohali, member BOG, Central University Goa, member UGC Expert Committee, past national president of Indian Association of Clinical Medicine, past national president IMA, Academy of Medical Science Specialties, principal investigators of various clinical trials, global and national, published more than 80 articles in different peer-reviewed journals, member editorial board of different peer-reviewed medical journals. With these few words of introduction, I now request Dr. Madhuchanda Kaur to kindly introduce our speaker, Dr. Rajib De, for further discussion on the plasma cell disorders for today's topic. Thank you to Dr. Madhuchanda Kaur.
Colleagues, welcome Rajib to this masterclass and all the academically interested PGTs and all those who are participating today in this very important masterclass. Actually, I think for the physicians, most important thing is understanding that all monoclonal antibody is not multiple myeloma. So there is a general disconnect between the physician and the hematologist, that when to treat, when not to treat, and when to just follow up these patients. So we have three scenarios: Magas, we have smoldering myeloma, and we have those who have got multiple myeloma which needs immediate attention. So I think Rajib will clarify these three scenarios and how the physician should connect with the hematologist in which scenario. Number two, I think what is very important nowadays is that even recurrent multiple myeloma has so many options. So there are several lines of chemotherapy that are available in the form of IV injection, subcut injections, oral therapy. So all patients should receive these options at various phases of their disease. So gone are the days that there are only 2 drugs for multiple myeloma. There are umpteen drugs. So we have a basket of options and we can really treat these patients down several lines of relapse. Bone marrow transplant also plays a very important role, which Rajib will clarify. I would also like to say that the physicians have very important role in the supportive care of multiple myeloma. Because multiple myeloma treatment needs a lot of support. We know that these patients have anemia, infection, so host of things that really need attention by physicians. And very important is the age group when multiple myeloma occurs, because then these patients might then have a lot of comorbidities, which should also be taken care of. So we have Magas, we have smoldering myeloma, we have multiple myeloma, we have relapsed myeloma, we have fresh myeloma, we have supportive care, and all these need attention by the hematologist in coordination with the physicians. So I think we'll have a wonderful discussion on 2-3 cases which Rajib has already picked up for discussion. To introduce Dr. Rajib De, we have a very enterprising young hematologist who's already the professor of Department of Hematology, NRS Medical College. And he is the clinical lead for the bone marrow transplant unit in Narayana Multi-Speciality Hospital. So with this few words, we are all eagerly waiting for the clinical case that Rajiv is going to present. And at the end, we can have a lot of question answer based on these cases. Over to Dr. Rajib.
Yeah. Very good morning, and thank you, Madhuchandadi. I express my regards to API, Dr. M.K. Roy sir, for giving me this opportunity to discuss the cases or highlight the issues related to plasma cell disorders, not only multiple myeloma, blood plasma cell disorders. As Dr. M.K. Roy sir and Madhuchandadi has already mentioned, that we are not going to discuss or treat multiple myeloma only. Multiple myeloma is only a part of monoclonal gammopathy, a part of the total gamut of plasma cell disorders. So where it differs, what are the other entities and which actually needs intervention and which doesn't need any intervention but needs to be followed up, that I'm going to discuss with few cases and mainly focusing on the issues related to multiple myeloma and plasma cell disorders. So I'm sharing my screen. Is it visible? Hello?
Yes.
Yeah.
Make it full screen, full
Make
screen.
it full screen.
Okay.
Yeah, it's okay.
So this is a case-based discussion on plasma cell disorders. As it is in forum of medicine, so I want to focus that first identified case of multiple myeloma, suspected multiple myeloma, was documented way back in 1844, and it was termed as malicious osseum. In 1844, in the journal published in London Medicine Journal, a 39-year-old woman, Sarah Newberry, was reported that she was having severe fatigue and bone pain from multiple fractures. And the case was reported by Dr. Solly S. And we are amazed with the amount of clinical suspicion at that point of time. His observation was the earthy matter of the bone is absorbed and thrown out by the kidneys in the urine. Body linen was stiffened by her urine. So he suspected that some bone materials are absorbed and going out through the kidney. And he also detected that urine was stiffened by the body linen was stiffened by the urine. So these kind of clinical observations was there at that point of time. And he said in 1845, he followed up the cases, and he sent that urine to Henry Benz-Jones. And he observed that, the physician observed that, when the urine was boiled, it became slightly opaque. And on the addition of nitric acid, it effervescence assumes a reddish hue and becomes quite clear. But as it cools, it assumes the consistency and appearance, which you see. Heat liquefies it. So what is it? He asked this question to Henry Benz-Jones. And then Henry Benz-Jones diagnosed what we know as Benz-Jones protein. And later on, we found that it is an M protein. So it was the amount of clinical acumen at that point of time. So later on, so it is probably the earliest documented case of multiple myeloma. And then we know that it is not only multiple myeloma, it is a basket of disorders, which is known as plasma cell disorders, which includes MGUS or MGUS, which Madhuchandadi has mentioned. It can be IgM, non-IgM, and light chain MGUS, then smoldering multiple myeloma, then multiple myeloma, plasma cell leukemia, light chain and heavy chain disorders. Then there can be a solitary plasmacytoma. Solitary plasmacytoma with or without minimal bone marrow involvement, and as well as primary amyloidosis. So these are the IMWG classification of plasma cell disorders. But in last year, just few months back, WHO published its 5th edition of World. WHO published its 5th edition of the hematolymphoid tumor classification. And this is the recent classification published by WHO for plasma cell disorder or monoclonal gammopathies. it included few more entities. One is cold agglutinin disease. We knew that in autoimmune hemolytic anemia, one type is cold agglutinin disease, and we consider this to be a benign disorder, but we need to look for that whether we are missing any lymphoproliferative disorder associated with cold agglutinin disease or not. But in the recent diagnosis, this cold agglutinin disease has been included under the monoclonal gammopathy, as well as there are IgM monoclonal gammopathy of undetermined significance, MGUS, non-IgM MGUS, monoclonal gammopathy MGRS of renal significance, and then immunoglobulin deposition disorder, that is a primary amyloidosis, light chain and heavy chain deposition disorder, as well as heavy chain disease. Then came the plasma cell neoplasms, or what we call a multiple myeloma group. It is plasmacytoma, plasma cell myeloma, plasma cell neoplasms with associated paraneoplastic syndrome like Poem syndrome, Tempe syndrome, and Ishop syndrome. So this is the newest classification of monoclonal gammopathies or plasma cell disorders under WHO 5th edition. So with this background, I'm starting with a case scenario. It is a 65-year-old male presented in OPD with history of generalized weakness, low back pain, and lower limb weakness. His baseline CBC revealed that hemoglobin was 10.5 gram per DL. It was a normocytic, normochromic. Total count was 5,500 with a normal differential, and platelet count was also normal. But peripheral blood showed a rouleau formation. So with this basic informations and CBC, the further investigations were done. The baseline biochemistry. The liver function test showed there is an alteration in the albumin globulin ratio, and alkaline phosphatase was normal. Urea creatinine was essentially normal. Serum calcium 10.5, which can be considered as a normal range, and serum LDH was 250. And X-ray lumbosacral spine showed there is a gross osteoporosis. So with this diagnosis, with these findings, then as there was an alteration, significant alteration in the albumin globulin ratio, so there was a possibility of a hyperglobulinemia. So whether it is a monoclonal, polyclonal, it is an inflammation related, whether it is related to degenerative changes or not. So the next investigation was done was serum protein electrophoresis, and it showed an M band. And M band immunofixation showing that is an IgG kappa. And serum free light chain ratio was 110.4, where kappa was 165 milligram per liter and lambda was 1.45. Beta 2 microglobulin was a borderline raised 3.2. So this is the total investigations and patient's history. So what is the diagnosis? And then next test was done, that is the bone marrow, because there is a M protein. Patient was symptomatic. So bone marrow showed there was an 8% clonal plasma cells. So clonal plasma cells was there, and it was 8%. So whether it was MGUS, whether it was smoldering multiple myeloma, or whether it was multiple myeloma. So let's see the definitions. The monoclonal gammopathy, we know it can involve the total immunoglobulin. It can involve a partial light chain or heavy chain immunoglobulin. There is an overproduction of immunoglobulin, but those immunoglobulins are coming from a single clone of plasma cells or B lymphoid cells. So that is the monoclonal gammopathies. So when the monoclonal proteins are produced from a single clone of plasma cells or B cells. Now, if we go into the IMWG criteria, International Myeloma Working Group Diagnostic Criteria of Multiple Myeloma, it showed that the clonal bone marrow plasma cells must be more than equal to 10%, or there should be biopsy-proven bony or extramedullary plasmacytoma, plus any one of the CRAB criteria. The CRAB criteria includes hypercalcemia, which should be more than 11 milligram per DL, renal insufficiency, that is creatinine clearance, should be less than 40 ml per minute, or serum creatinine more than 2 milligram per DL, anemia, that is hemoglobin should be less than 10 or more than 2 gram per DL less than the patient's baseline value, and bony lesions includes one or more osteolytic lesions by skeletal radiography, CT, or PET. So the criteria is a bit stringent. in the WHO 2008 criteria, any amount of clonal plasma cells were sufficient for the diagnosis of multiple myeloma if there is a CRAB criteria. But here in these patients, we see that there is no CRAB criteria, and the percentage of plasma cells is also 8%. It is not 10%. So whether we are dealing with a smoldering myeloma, MGUS, or it is a multiple myeloma. So now the latest IMWG criteria has defined some myeloma defining events. So what are those myeloma defining events? So if there is no end organ damage, no CRAB criteria, if the clonal bone marrow plasma cells is more than equal to 60%, it can be diagnosed as multiple myeloma and we should treat them, but it is not there in our case. If the involved serum free light chain ratio was more than 100, where the involved free light chain must be more than 100 milligram per liter, then also it is a multiple myeloma and we should treat them. If there is more than one focal lesions on MRI, not only X-ray, if on MRI there is more than one focal lesion where the size of the lesion is at least 5 millimeter in size, then also it fulfills the criteria of multiple myeloma by MDE, myeloma defining events. So by incorporating these myeloma defining events, probably we are dealing with a case of multiple myeloma as the patient's FLC ratio is more than 100. So in addition to CRAB criteria, which we knew so far, that is calcium elevation, renal dysfunction, anemia, and bone disease, there is addition of the SLIM criteria. So the CRAB has become SLIM now. What is the SLIM? S means 60% bone marrow clonal plasmacytosis. Li means light chain ratio is more than 100, and MRI more than one focal lesions. And why this SLIM criteria has been included in the diagnostic criteria of multiple myeloma? So different studies have shown, so there is more than 80% risk of progression to multiple myeloma in 2 years if the patient is diagnosed with this SLIM criteria. So SLIM criteria means in next 2 years, more than 80% will progress to frank myeloma. So that's why the SLIM criteria has been included in the diagnostic criteria of multiple myeloma, and because of the SLIM criteria, our patient is diagnosed as multiple myeloma. Now a bit about epidemiology, which Dr. M.K. sir has already mentioned. It constitutes 1% of all malignancies and 10% of hematological malignancies. Although median age of diagnosis is around 65 to 70, but in our country, it is at least 1 decade less. We get in the 5th decades, the median age of multiple myeloma in our country is the 5th decade, not the 6th decade. And 15% cases, less than 60 years, we get 15% of cases of multiple myeloma. And almost all multiple myeloma patients progress from this asymptomatic MGUS, then smoldering, then the frank multiple myeloma. If a patient who is diagnosed with MGUS, there is 1% risk of progression to multiple myeloma each year. But if it progresses to smoldering myeloma, there is 10% risk of progressing to multiple myeloma each year till first 5 years, and then it gradually reduces 3%, then 1.5%. So smoldering myeloma has a 10% risk of progression to multiple myeloma in first year. And this is the IMWG criteria of MGUS and smoldering. The basic difference is in MGUS, the M protein must be less than 3 gram per DL and bone marrow plasma cells should be less than 10%. In smoldering myeloma, M protein will be more than equal to 3 gram per DL, but bone marrow plasma cells will be more than equal to 10%, but there will not be any end organ damage. That means CRAB criteria or SLIM CRAB criteria will not be there in smoldering myeloma. And in multiple myeloma, any amount of M protein along with 10% clonal plasma cells and SLIM CRAB criteria or figures of end organ damage should be there. So this is called a pre-malignant clonal plasma cells. Now MGUS can be divided into non-IgM MGUS, which progresses to multiple myeloma, 80% of multiple myeloma. IgM-MGUS can progress to Waldenstrom macroglobulinemia or lymphoplasmacytic lymphoma. They can have a hepatosplenomegaly. And there is light chain MGUS, which can progress to light chain myeloma. There is 2% of myeloma originates from the light chain MGUS. Now we can see that there is a steady progression of this MGUS or smoldering to multiple myeloma. And if we follow the patients, there is gradual increase of the M component also from MGUS to smoldering to multiple myeloma. There is gradual increase in the M component, gradual increase in the bone marrow clonal plasma cells, and the development of the end organs. That we can see. This MGUS criteria I have already mentioned. I am not going into detail because it is there in the IMWG criteria. But only one thing is the light chain ratio for light chain MGUS should be less than 0.26 or more than 1.65. But in multiple myeloma, it is an abnormal light chain ratio. For solitary plasmacytoma, it should fulfill all the criteria. That is a biopsy-proven solitary lesion or bone or soft tissue. The bone marrow should have no evidence of clonal plasma cells, and normal skeletal survey or MRI of spine and pelvis. Solitary plasmacytoma with minimal marrow involvement. This is a new criteria where there is a solitary plasmacytoma, whether in the bone or extramedullary tissue. But the bone marrow should contain clonal plasma cells, but it must be less than 10%. So this is called solitary plasmacytoma with minimal bone marrow involvement. And then came the plasma cell leukemia. We know there must be, it should fulfill the diagnostic criteria of multiple myeloma. That must be there. In addition, there should be 5% or more plasma cells in the peripheral blood smear by conventional assessment. That is conventional Giemsa stain or Wright stain. So it is called a plasma cell leukemia. So these are the diagnostic criteria. So if we consider the total monoclonal gammopathy gamut, around 50 to 60% are MGUS, around 20-25% are multiple myeloma, and then other entities are relatively less. So starting from the MGUS, the patient can progress to M protein related disorder like monoclonal gammopathy of renal significance, AL amyloidosis, or it can progress to tumor progression like smoldering, high risk smoldering, CRAB, multiple myeloma, plasma cell leukemia. And who is responsible for this progression? The responsible for progression is the genetic changes. Usually it has been found that from a normal cell, when the cell turned to MGUS, the cell turned to MGUS when there is some primary cytogenetic abnormalities. And what are those primary cytogenetic abnormalities? They are either IgH, immunoglobulin heavy chain translocation, that is any translocation related to 14q32, or there is hyperdiploidy or trisomy of uneven chromosomes. So if it is more than 50% a chromosome number, so these are the primary cytogenetic abnormalities which turn the normal cells into MGUS. And gradually, then MGUS acquire more cytogenetic challenges, more mutational challenges. And these mutational challenges convert them to smoldering to multiple myeloma. So if the further secondary chromosomal abnormalities, secondary mutations doesn't occur, then the MGUS remains in the MGUS phase for years, maybe lifelong. But if the further mutations, like 414 translocation, 17p deletion, 13q deletion, NRAS, KRAS mutations, then gradually it progresses to the further aggressive disorders. And depending on the mutation affected, the aggressiveness of the disease depends. Bone marrow microenvironment plays a very important role in the myeloma pathogenesis because myeloma cells interact with the bone marrow stromal cells. They produce local cytokines and they causes different cytokine production like VEGF, IGF, which is responsible for angiogenesis. We know that multiple myeloma, bone marrow, or plasmacytoma is very vascular. That is why we use this thalidomide or lenalidomide, which plays as an anti-angiogenic factor. So if we can block the angiogenesis, the myeloma cells die because they depends on this angiogenesis. Then we know that very well known this rank and rankle. That is, rank is responsible for the osteoclast activities, and this myeloma cells produce rank ligand, rankle. This rank ligand binds to rank on the surface of the osteoclast and causes the osteoclastic activities and prevent the osteoblastic activity. That is the responsible for the bony lesion. So it is not the actual myeloma cells which causing the lytic lesions. The myeloma cells producing the cytokines rankle, they activates the rank surface receptor on the surface of the osteoclast. In that way, it activate the osteoclast, and it is the osteoclastic activity induced by the myeloma cells which is responsible for the lytic bony lesions. Now the clinical features. The clinical features are because of different causes. One is marrow infiltration by the plasma cells, which causes bony destructions, anemias, hypercalcemia, bone pain. There can be immune deficiency because we know that the multiple myeloma is the malignant counterpart of the plasma cells which produce our normal immunoglobulins. So there will be increased abnormal immunoglobulins, but normal immunoglobulin will be less. And that's why there will be increased chance of infections. And that's why we need to give a specific prophylaxis. Most of the important cause of death in multiple myeloma is pneumonia or sepsis because of this immunoparesis. And then AM protein also can cause renal dysfunctions and amyloidosis. So around 70% patients presented with anemia. Then bone pain can be 50 to 60% patients. There can be 50% patient can present with elevated creatinine, fatigue, general weakness around 30%. So these are the different percentage by which the patients can present with different clinical features. Infection is definitely more, as I mentioned, because there will be hypogammaglobulinemia, but abnormal protein will be high, but normal immunoglobulin will be less. How to evaluate? Evaluation, I've already mentioned. Once we suspect a case to be a case of multiple myeloma, we need to do a peripheral blood smear. Then the baseline biochemistry, that is liver function test, which can give an idea of albumin globulin ratio, which can give an hint that globulin is high, so it can be a case of gamma globulinemia. Then renal function test, urea, creatinine, whether creatinine is high or not. Then basic biochemistry like LDH and calcium. Calcium is a diagnostic criteria for multiple myeloma. LDH is a prognostic marker for multiple myeloma. And then we need to do the serum protein or urine electrophoresis to document whether there is AM protein or not. Then we need to do the bone marrow test to prove whether it's clonal plasma cells or not. And then we need to restratify and start treatment. So this is the peripheral blood having rouleau formation. If for any reason there is hypergammaglobulinemia, whether it is a polyclonal or monoclonal, there will be rouleau formation. Rouleau formation is not that it is a monoclonal protein. It is the sign that there is a hypergammaglobulinemia. And plasma cells can be detected in the bone marrow, or in case of plasma cell leukemia in the peripheral blood, and we need to do a bone marrow biopsy. Why we need to bone marrow biopsy? Because the plasma cell infiltration is not homogeneous in the bone marrow. It is a patchy involvement. So we need to do bone marrow biopsy because with aspiration, we can miss plasma cells in the bone marrow. Then we need to demonstrate the monoclonal protein either by serum and or urine electrophoresis. Number 2 is immunofixation, serum or urine immunofixation, and then light chain ratio. Light chain ratio we should do from serum because the light chain abnormality in the urine is not standardized. So we shouldn't do the light chain assay from the urine, but serum from electrophoresis and immunofixation we should do from bone marrow, from blood as well as from the urine. Okay, so this is a monoclonal protein. We can see it is an albumin, then alpha 1, alpha 2, beta 1, then gamma globulin. Then it is a gamma globulin high. And then by immunofixation, we can identify whether it is which type of immunoglobulin it is. So in this case, it is a polyclonal. In this case, it is a kappa light chain. Here it is a IgG kappa. Here we can see there is a lambda light chain only. So the M protein can be just simple a light chain. There may not be a heavy chain. That it is not that always the monoclonal protein will be accompanied by heavy and light chain. It can be light chain disease only. So, and that can be proven by immunofixation. Imaging, definitely lytic lesions are there. But what is the ideal imaging? Imaging we can do by skeletal survey. But by skeletal survey, all the cases of lytic lesions we can't prove. So it is the whole body low dose CT, which is a recommended, or FDG PET, which is a recommended skeletal survey for diagnosing multiple myeloma as per IMWG criteria. So X-ray, low dose CT, FDG PET, or MRI. MRI should be done if we suspect any neuropathy, suspecting that there is a spinal fracture which can causes neurocompromise, or if we suspect a case of plasmacytoma, then we need to do an MRI. So this is the recommendation for the skeletal survey. If we don't have any, if the patient can't afford CT, then how many X-rays we need to do for skeletal survey? So there is a guideline. We need to do PA view of chest, AP and lateral view of cervical spine, thoracic spine, lumbar spine, humerus and femoral, AP and lateral view of skull, and AP view of pelvis. So that is the sufficient X-ray which we can do. Now, clonality is very important. So how we can prove that it is a clonal? Clonal means we need to prove two things. This is very important. One is we need to show that there is a clonal M protein, monoclonal M protein. So if we find a monoclonal M protein in the serum or urine, and if we find plasma cells in the bone marrow, that doesn't mean that the plasma cells are clonal plasma cells, because the source of monoclonal M protein can be from a MGUS, can be from a lymphoid malignancy. Suppose the patient is having lymphoid malignancy, lymphoma, that can be a source. In different collagen vascular disease also, the patient may produce some monoclonal M protein. So it is not that if I find M protein in the serum and we find some plasma cells, that means it is a clonal plasma cell. So separately, we need to prove that it is a clonal plasma cells. How can we prove? By doing immunohistochemistry or flow cytometry from the bone marrow. And the clonality is established by this kappa lambda ratio. If kappa lambda ratio is more than 4:1 or less than 1:2, then only it is a clonal plasma cells, clonal M protein. And bone marrow plasma cell percentage should preferably be estimated from a core biopsy specimen that I've already mentioned. Now, once we diagnose it, we need to do a restratification. Recertification can be done in two ways. One is tumor burden, that is Salman-Duri, and international staging system. And then there is a disease biology. What is the cytogenetic abnormalities? Now, this is the international staging system. International staging system, we use only two criteria. One is serum beta-2 microglobulin, and another is serum albumin. If the serum albumin is more than 3.5 gram per DL, and serum beta-2 microglobulin less than 3.5 milligram per liter, it is stage 1. If serum beta-2 microglobulin is more than 5.5, it is stage 3, and which is not stage 1 or 3, it is stage 2. But it only gives idea about the tumor burden, but it doesn't give any idea of the disease biology. And definitely ISS has significant prognostic significance because it is actually directly related to the overall survival. Depending on the stage, the survival differs from 5.1 to 1.7. But this cytogenetic risk group, these are important as a disease biology. Standard risk are trisomies, translocation 1114 and 614. Intermediate risk is 414 and 1q gain. and high risk is 14, 16, 14, 20, and 17p. So this is the cytogenetic risk, and that's why, and this cytogenetic risk has also a significant prognostic importance. But then there is revised international staging system, which combines the ISS, that is tumor burden, as well as cytogenetics, that is disease biology. And then there is RISS. According to RISS, the stage 3 includes high risk cytogenetics, that is translocation 414, 1416, and deletion 17p, or elevated LDH. If it is there, it is stage 3. If beta 2 microglobulin is more than 5.5, then it is also stage 3 along with this high risk criteria. Stage 1, absence of high risk cytogenetics along with conventional stage 1 by ISS, and all other is stage 2. And how we manage then? So we diagnose our case as a case of multiple myeloma, and then we re-stratified according to RISS, not only ISS, RISS. And once it is done, then we should plan our treatment. Then how we plan our treatment? Then, we all know, we just, before starting my lecture, it was discussed that transplant is the most important pivotal point in the management of multiple myeloma. So when we decide to treat multiple myeloma, we need to decide whether the patient is transplant eligible or transplant non-eligible, because the outcome depends whether we can do transplant or not. But we can't do transplant upright. First, we need to, because in multiple myeloma, what we do an autologous bone marrow stem cell transplant. That's why we need to bring the disease under control, and then we can do this transplant. And transplant is also not sufficient, because we have seen that ultimately all the multiple myeloma patients will relapse, and that's why we need to give a maintenance therapy after transplant. So we need to decide whether transplant eligible or ineligible. Then we give an induction therapy, then consolidation. Consolidation are of two types. Those who are eligible for transplant, we give consolidation by doing stem cell transplant. So we need to remember that the stem cell transplant in multiple myeloma is used as a consolidation therapy, not as a curative therapy. It's a consolidation therapy. And then post-transplant maintenance. Those who are transplant ineligible, there what we do, we give induction therapy for prolonged period, and then we give a maintenance therapy. And if our goal is to reach to the reduce the tumor burden to the negligible stage, but then how we can measure the tumor burden? Recently, we can identify the tumor burden by MRD or minimal residual disease approach, but MRD till now in multiple myeloma is used as a prognostic marker. So if MRD is positive, prognosis is poor. If negative, prognosis is good. But we don't change our treatment depending on the MRD, the way we do in case of acute lymphoblastic leukemia. Now, as we mentioned earlier, that we have a plethora of medicines for treating multiple myeloma. Till 1999, in the last century, there was only limited therapy for multiple myeloma. That is melphalan and prednisolone. We used to give melphalan and prednisolone. Most of the patients would relapse or not go into remission, because less than 10% patient will go into CR with MP. But in this decade, one by one, these newer agents came. First landmark was thalidomide in 1999, then came bortezomib, then lenalidomide, and in the last decade, there is a plethora of small molecules, targeted therapy, monoclonal antibodies for the management of multiple myeloma, along with CAR T-cell therapy. So we first determine the transplant eligibility. Usually, if the patient is older than 65, the patient may not be eligible, but the biological age is much more important than the chronological age, and whether the patient is having different comorbidities or not. Performance status is important. And along with the treatment of multiple myeloma, we need to give a supportive care. And so it is actually a multidisciplinary approach. First, the patient usually land up to physicians, and then for the treatment of multiple myeloma, the support for all the disciplines, that is hematologists, nephrologists, neurologists, general physicians, orthopedics, radiotherapy, as well as physiotherapy. These things are important. Then there is a response criteria: stringent response, complete response, VGPR. A new term is there for multiple myeloma. Very important term is VGPR, very good partial response, then partial response. Now, CR means there should not be any monoclonal protein. There should not be any clonal plasma cells in the bone marrow, and the light chain ratio should be normal. In CR, there should not be any monoclonal proteins, but light chain ratio may be abnormal, but no clonal plasma cells in the bone marrow. Very good partial response means there should be more than equal to 90% reduction in serum M protein. So for the transplant eligibility, the patient must be VGPR or better, very good partial response or better. Otherwise, the advantage, the benefit of transplant cannot be provided to the patient, because the disease will relapse very shortly. So if the patient can't reach to the VGPR status, then transplant advantage is not there. So this is basically the treatment of multiple myeloma along with maintenance therapy. Smoldering active myeloma, we give therapy and we bring the patient into remission. We usually don't say that multiple myeloma, we can cure multiple myeloma. We can control multiple myeloma, because all the multiple myeloma eventually relapses. So when the patient relapses, we have different strategy. And to delay relapse, in fact, the transplant also can't prevent relapse. It delays the relapses. And to delay the relapses, we have another strategy, that is the maintenance therapy. So this is the strategy which we mentioned. And the treatment should be risk-adapted therapy. So how to initiate therapy? It should be rapidly and effectively control disease, reverse the disease-related complications, decrease the risk of death. There should be minimal toxicities, and not most important is that treatment should not interfere with stem cell collection. Because we know that in the last century, we used to treat the multiple myeloma patients with oral melphalan and prednisolone, MP. But melphalan is a stem cell toxic agent. If we treat the patient with melphalan, then we can't get stem cells. We can collect stem cells from the patient. And that's why if we plan for transplant, we should not give any multiple myeloma patients melphalan. Melphalan is used in the transplant. So therapeutic agents are now immunomodulatory agents, thalidomide, lenalidomide, and pomalidomide. There can be proteasome inhibitors like bortezomib, carfilzomib, ixazomib. Traditional chemotherapy, that is cyclophosphamide, vincristine, melphalan, and monoclonal antibodies like daratumumab, elotuzumab, etc. So these are the important immunomodulatory drugs which we can use. They are anti-angiogenic, and there are different doses schedule for them. There can be proteasome inhibitors. They actually inhibit proteasomes, and they inhibit the anti-apoptotic NF-kB kappa beta pathway. And that's why it induces apoptosis. The proteasome inhibitors, by inhibiting proteasomes, they induces the apoptosis of the myeloma cells, like bortezomib, carfilzomib, etc. And they have different doses, different route of administration. I'm not going into detail for them. And ixazomib is a proteasome inhibitor which can be used as an oral drug. But what to choose for induction therapy then? This is the conventional therapy didn't improve our outcome much. That's why the novel combination we use. The novel combinations, we can see that they have a significant improvement in overall survival and VGPR compared to the conventional agents.
Yeah.
And with these novel combinations, we can see that the overall survival has significantly increased and increasing day by day. Then what is the standard induction therapy? So this is a landmark trial published in Lancet, that is VRD. VRD means bortezomib, lenalidomide, and dexamethasone versus len and dexamethasone. It showed that there is a significant improvement in overall survival as well as progression-free survival. So usually VRD, this 3-drug combination, is a standard therapy for induction therapy. We can use this VTD also, that is bortezomib, thalidomide, and dexamethasone versus bortezomib, cyclophosphamide, dexamethasone. Usually we use VCT in case of renal compromise. And so these are triplet therapy. The proteasome must be included, dexamethasone must be included, and third drug usually is an immunomodulator. So that is the strategy. Then we consolidate the therapy with autologous stem cell transplant, or in transplant ineligible patients, we can use the multi-drug chemotherapy for induction. Timing of transplant. Usually it should be done after 3 to 4 cycles of induction when the patients achieve VGPR. But in standard risk patients, we can collect the stem cells and cryopreserve it, and we can delay the transplant till the patient relapses. Although there is a bit difference in progression-free survival, but overall survival is same in early transplant as well as in delayed transplant. So progression-free survival is improved by autologous stem cell transplant versus conventional therapy. It has been proven by different trials and by meta-analysis also. But overall survival benefit has been shown by a single trial. But recently one trial published, and it showed there is almost 1 year overall survival benefit by autologous stem cell transplant. In the era of novel agents also, when these novel agents came, people suspect that probably in the era of novel agent, there will not be some benefit of stem cell transplant. But in the era of novel agent, it has been seen that before transplant, compared to before transplant, after transplant, the CR rate increased. After transplant, how much increased? It increased around 20%, around 9 to 17% increase in the CR rate after bone marrow transplant. So this is a novel induction agent. This is a landmark trial published in 2017 in NEJM, and it showed that RVD, which is standard therapy, in RVD novel agent therapy also, there is advantage of transplant as far as progression-free survival is concerned. So it is statistically significant. But overall survival, definitely it is not statistically significant. Overall survival is statistically not significant because of different new novel agents. So if the patient relapses, we give second-line therapy, third-line therapy, fourth-line therapy. So we don't let the patient die. We give one or other therapies because numerous therapies are available now, novel therapies are available now. So it is very difficult to have an impact on overall survival. Progression-free survival has a definite impact by transplant. So that I have mentioned already, I can skip. So CR rate increased by 7 to 19%, around 20% post-transplant. So upfront or delayed transplant. So this is a study which, they have done PBSC collection after 3 induction cycle, and then they waited, continuing the therapy till the patient has progressed or relapsed, and then they did the transplant. And in another group, 350 patients, they give 3 cycles of induction, then they did the transplant, and then they underwent the maintenance therapy. It has been seen that there is a difference in progression-free survival, 50 versus 36, but overall survival is same. So delayed transplant is feasible with no decrement in overall survival. So it is now recommended that in standard risk patients, we may delay the transplant, but in high risk patients, we should do transplant at the first remission status. So it is there. So transplant is still valid in the era of novel agents. And maintenance therapy. Maintenance therapy has got a significant importance because there is increased chance of relapse if we don't put the patient. So after giving a intensive therapy, induction therapy with novel agents, then doing transplants, then also patients are relapsing within 2 years. Then this concept of this maintenance therapy came, and it has been shown that time to progression is 50 months, those who are on lane maintenance versus 27 months, those who are on placebo. So maintenance therapy is very important in transplant. We can give maintenance with bortezomib in high-risk patients, or we can give maintenance with lenalidomide. So how long we can continue maintenance? Because there is some reports of secondary malignancy if we do maintenance with lenalidomide. And there is significant neuropathy, peripheral neuropathy, if we continue treatment with bortezomib. So, but now it is recommended that we need to continue maintenance till disease progression and manage the side effects by supportive care only. Allogeneic stem cell transplant is myeloma is experimental. I am not going into details. So this is the treatment algorithm of newly diagnosed multiple myeloma. There is novel agent-based triple therapy 3 to 4 cycles to do transplant after 3 to 4 cycles, or cryopreserved stem cells and do transplant when the patient relapses. In high-risk patients, we need to usually give a 4-drug regimen, that is VRD plus DARA. It is a better option, and then early transplant. Transplant ineligible, we continue induction therapy for 8 to 12 cycles, then we do the maintenance. So for these patients treated with VRD, remission achieved with maintenance. And once the remission achieved, the patients were followed up. And after following up, suppose this is a case of basically relapse patients. So the 58-year-old female diagnosed with multiple myeloma, ISS2, cytogenetics gain of 1Q gain. So it is an intermediate risk. So treated with the standard regimen, autologous stem cell transplant done and put on maintenance therapy. But after 3 years of maintenance, the patients presented with hematological relapses. So what is called biochemical relapse? What is called a clinical relapse? The biochemical relapse is if the serum M protein is more than 25% from the lowest level of M protein, if there is more than equal to 25% increase from the confirmed response of FLC ratio, or bone marrow plasma cells increase more than 10%, then it is called a biochemical relapse. But when this biochemical relapse is associated with the Crab criteria or slim Crab criteria, then it is a clinical relapse. In biochemical relapse, usually we should do close monitoring. There is no indication for active aggressive treatment. But if in addition to biochemical relapse, if the patient is having clinical relapse against slim criteria, then we need to treat with aggressive treatment. Now, how we treat relapse refractory multiple myeloma? There are some patient-related factors, that is the patient's comorbidity, age, and the presence of previous treatment which patient received. So considering all these things, we need to decide on the relapse refractory therapy. So it has been seen that if the first relapse occurred after 6 months of completion of the previous treatment, we can give the same therapy. But if the patient relapses while on therapy, we need to change therapy. And we have a lot of options. Different novel agents are there. Even CAR T-cell therapy and venetoclax can be used. So for first relapse, usually if the patient is not refractory to monoclonal antibodies, we need to give monoclonal antibodies, that is daratumumab, because multiple myeloma has a surface CD38. And daratumumab is an anti-CD38 monoclonal antibody. So some combination involving daratumumab. And in daratumumab refractory patients, we can use carfilzomib or other alternatives. If the patient is refractory to len, then we can give again different combinations like daratumumab, pomalidomide, carfilzomib. So all different permutation combinations can be given. These are the newer novel agents like histone deacetylase inhibitors, panobinostat. So that blocked the agrigosome pathway. This is the dose, and this is used for the relapse refractory multiple myeloma. Datumab has now become an important component of therapy in either relapse refractory or high risk treatment upfront. This is the dose 16 milligram per kg, and day 1, 8, 15, every week, once a week for 2 cycles, and then once every 2 weeks. So it is an anti-CD38 humanized monoclonal antibody. There can be elotuzumab. This is also humanized IgG kappa. This is an anti-SLAM-F small molecules monoclonal antibodies used in relapse refractory multiple myeloma, and these are the emergent therapy like CAR T cell therapy and bispecific antibodies. Then the management of multiple myeloma is incomplete without supportive care, because treatment will take time to have its effect. But usually patient present with different organ damage, and we need to handle those organ damage starting from management of anemia, bone disease, neuropathy, infections, renal disease, coagulopathy, and general supportive care. So these supportive care is very important for the management of multiple myeloma. The SRE, skeletal-related events, these are important comorbidities of multiple myeloma. They contribute to a reduced quality of life. Myeloma bone disease, it is a very significant abnormality in the bone disease. Usually SRE includes vertebral fracture, spinal cord compression, and pain or other pathological fracture. And we know, as I already mentioned, that the Rankel-directed pathophysiology is responsible for the bone lesions. And this is the balance between Rankel and OPG, which determine the bony health of multiple myeloma. And that's why we have different agents to prevent or treat the multiple myeloma bony disease. So lytic lesions or multiple myeloma bone disease can be treated with different bisphosphonate, cementing augmentation technology, radiotherapy, especially if there is a spinal fracture or extramedullary plasmacytoma, which is compressing the nerve roots, or for surgical intervention if there is an acute neural compromise. So bisphosphonates, we know that bisphosphonates can decrease the osteoclastic functions. And it prevents the activity of osteoclasts and promotes the activity of osteoblast. There are different generations. Usually we prefer either zoledronic acid, or in a renal compromised patients, we use pamidronate. Alternative options is denosumab in renal compromised patients, which is a fully human monoclonal anti-Rankel antibody. We know that myeloma cells produce Rankel and activates osteoclast. So it is an anti-Rankel antibody which stops the osteoclastic activities. Then vertebroplasty, kyphoplasty, these are important, especially in cases of vertebral damages. For that, interventional radiologists or orthopedics can do this balloon kyphoplasty or vertebroplasty. Radiotherapy is important, especially in cases of extramedullary plasmacytoma causing an organ damage, especially the neural damage. And it is very important component for reducing pain also, radiotherapy. It is a palliative radiotherapy. Neuropathy can be because of multiple myeloma per se and can be drug induced, because thalidomide and bortezomib, they are very bad agents for neuropathy, and carfilzomib also can cause neuropathy. So in neuropathy, different agents can be used, whether it is a thalidomide induced, whether it is a bisphosphonate induced neuropathy. So usually gabapentin or pregabalin, these things should be given. And by modifying the route of administration, we can reduce neuropathy. Previously, we used to give intravenous bortezomib. Now we give subcutaneous bortezomib. Subcutaneous bortezomib can actually reduce the neuropathy. And infection, definitely the infection is very high in multiple myeloma, as I saw in the chat section, that rightly one doctor mentioned that the infection is many multiple myeloma patients present with infections. So there is 7 to 10-fold higher viral infection as well as the pneumonia infection. And that's why we need to give an antiviral prophylaxis those who are getting bortezomib, because there is herpes zoster activation. We should give vaccination for pneumococcal as well as annual influenza. It is a must before starting therapy. Once the patient is diagnosed with multiple myeloma, we should vaccinate all the multiple myeloma patients, because most of the multiple myeloma patient dies with pneumonia. Anemia is a significant cause of morbidity. We can treat anemia with erythropoietin, but the erythropoietin level should be measured. If it is more than 500, then erythropoietin doesn't have much role. But if it is less than 500, erythropoietin should be given in all cases of multiple myeloma presenting with anemia. Renal impairment is a serious problem. Then, and the most common cause of renal impairment is a cast nephropathy. It rarely affects the glomerulus and causing nephrotic type of proteinuria, but most commonly it is a cast nephropathy, and that's why proper hydration and high threshold dialysis is important for multiple myeloma associated renal disease. And some chemotherapeutic agents are very important for managing multiple myeloma with renal disease, like cyclophosphamide, VCD or VTD. We should avoid lenalidomide in cases of renal disease in multiple myeloma. Whereas thromboembolism, multiple myeloma per se is a thrombotic condition, and we also treat the patients with thalidomide and lenalidomide, which are thrombogenic. So all the patients who are on len or thalidomide should be given aspirin as a prophylaxis. Now, the multiple myeloma is assessed by MRD. It is an NGS-based or flow cytometry-based MRD, minimal residual disease, but it hasn't come into the normal guideline of multiple myeloma management. It has a prognostic value. We don't change our treatment depending on the MRD, but in future, as MRD utilization in other hematological disorders like ALL and in some cases of AML. So I think in future, for multiple myeloma disease assessment, MRD will be a standard approach. Now, we know that transplant is an important pivotal role in multiple myeloma. So some basic information about transplant. In hematopoietic stem cell transplant, we don't do any operation. We just collect the stem cells. We mobilize the stem cells from bone marrow to blood. We collect the stem cells from the blood, and then we give a high-dose conditioning regimen. And we give high-dose melphalan, 200 milligram per meter square dose of melphalan to a patient of multiple myeloma whom we are doing transplant. That way, we actually destroy the bone marrow. The count becomes 0. Then we infuse the collected stem cells, which we have collected after 3 to 4 cycles. Then we infuse the stem cells, and this is the apheresis machine by which we collect the stem cells. We cryopreserve stem cells. If we delay the transplant, then we collect the stem cells after 3 to 4 cycles, we cryopreserve, and then we transplant when the patient relapses. But when we do an immediate transplant, the cryopreservation is not required. Then we thaw and give transplant. This is the rate of bone marrow transplants in India. Around 2,000 to 3,000 transplants are done every year. And the most common cause of transplant in India now is multiple myeloma. 55% of the transplant of autologous transplant are done in case of multiple myeloma only. So that's why, so in worldwide, in nationwide, the most common cause of autologous stem cell transplant is multiple myeloma. And the number of transplant centers are increasing. This is the BMT team in Narayana Hospital. So the high level of suspicion is very important in case of multiple myeloma, because the multiple myeloma can present as a renal disorders, can turn up to an orthopedician, can present with low back pain, even can present with simple infection. So the presentation can be varied. The proper diagnosis should be made by peripheral blood and M protein assessment by serum protein electrophoresis, immunofixation as serum-free light chain assay. Bone marrow should be done not only for morphology, but by immunohistochemistry to prove that the plasma cells are pleural plasma cells. And once it is diagnosed, then fish or cytogenetic study should be done for risk assessment. Once risk assessment is done, then therapy should be planned. And all multiple myeloma patients should be transplanted. Post-transplant maintenance therapy should be given. And the most important care of multiple myeloma is supportive care. We should not forget. And that's why the treatment of multiple myeloma is a multi-speciality management involving physician, hematologist, orthopedician, radiotherapist, transfusion medicines, and all. Thank you. So I'll be happy to take any questions.
Thank you, Rajib. Let us start with questions first, and then I will put some comments and questions.
Okay, ma'am. So, less than 20% means I actually understand. Basically, light chain disease definitely depending on what is the status of the light chain disease. Whether it is a light chain MGUS. If it's a light chain MGUS, then we need to follow the patients. But if it is a light chain myeloma, fulfilling light chain means when we do the serum protein electrophoresis, there is an M protein. But when we do immunofixation, there will be spike in the light chain section only, not in the heavy chain section. So it will be either kappa or lambda. Sometimes in light chain disease, it is not obvious in the serum. So we need to do 24 hours urinary protein electrophoresis as well as immunofixation for light chain disorder. And if it fulfills the criteria of light chain plus slim criteria, slim crab criteria, then we should treat this patient. But if it is light chain MGUS, we need to follow up the patient, not to treat the patient.
Any other question?
Why ALP remain normal, sir? Because ALP usually increases when there is an osteoblastic activity. So, and that's why ALP is not high. Alkaline phosphatase is not high in case of multiple myeloma. It is usually it is an osteoclastic activity is there. What to do if after 4 cycles VRD only 25% AM protein decrease? So if after 4 cycles of VRD only 25% AM protein is decreased, so then the disease is a stable disease. In stable disease, after 4 cycles VRD, my opinion, first to see whether what is the cytogenetic abnormality is there. So if it is an cytogenetic aggressive abnormality is there, then we need to change the or. If there is cytogenetic abnormality is not there, then also, if after 4 cycles there is only 25% reduction, then it is refractory to the regimen. Then we need to change the protocol. It is my opinion. Change means if the patient is getting thalidomide, VRD, so we can change to carfilzomib or pomalidomide and to see whether the patient achieve at least VGPR. If the patient achieves VGPR, then we can do it.
There is one question on non-secretory myeloma. Rajib, just take it.
2% is non-secretory multiple myeloma. Hello, ma'am.
Yes, please continue.
So around 2% is non-secretory multiple myeloma, and it is really very difficult to diagnose non-secretory multiple myeloma because here we in real non-secretory multiple myeloma, most of the non-secretory multiple myeloma often we get an alteration in the FLC either in the urine or in the serum. But one point I need to mention that we should, when we are suspecting a multiple myeloma and serum protein showing no M protein, we should do 24 hours urinary protein for light chain assessment. If all are negative and our suspicion is high, then the serum bone marrow immunohistochemistry or flow cytometry, the clonal plasma cells, as well as SLIM criteria, these are diagnosis of non-sickle multiple myeloma. And
Actually, Rajiv, this was a nomenclature quite few years back, when only serum protein electrophoresis was.
Exactly.
So much sophisticated and precision investigations now available. We hardly find any non-sickle myeloma.
Hardly, because
So, can I make one question, Madhuchanda?
Yes, please.
So one thing, we have got a patient who has got a typical grape-like cell in the bone marrow, but the percentage was around 8%, and the serum protein electrophoresis also showed that it's the case of, M band is also present, as well as immunofixation. So should we treat this patient? Less than 10%, but typical grape-like multiple myeloma cells, as suggested by the pathologist.
Yeah, grape-like cells means those are immunoglobulins, usually morphologically.
Yeah.
But we should prove that whether those plasma cells are clonal plasma cells or not by doing immunohistochemistry or flow cytometry. So, but if it is less than 10% and there is no CRAB criteria or SLIM criteria, then it is a smoldering multiple myeloma. We need to closely observe these patients, but if there is any end organ damage, features of end organ damage, then it should be treated. Smoldering myeloma also, there is a criteria of high risk smoldering myeloma. High risk smoldering myeloma and having high cytogenetic abnormalities, those patients also should be treated not with a triple drug therapy, but with a double drug therapy. That is lenalidomide plus dexamethasone, or can be single agent lenalidomide.
Another thing, you have told that on MRI, if you find 2 lytic lesions, then only on that basis you can diagnose.
Now,
on MRI. Can it be?
Yeah.
Can you differentiate from a lytic metastatic of some
there is
carcinoma like this? Yeah.
To diagnose multiple myeloma, there should be 3 criteria. One is some form of M protein should be there.
Okay.
Either serum or urine. That can be picked up by serum protein electrophoresis or immunofixation or alteration in the SFLC ratio, serum-free light chain ratio. So this is one criteria. Second is proof of clonal plasma cells in the bone marrow or plasmacytoma. And point 3 is CRAB criteria. Now, in addition to CRAB criteria, there is 3 more criteria. There is SLIM CRAB. That is MRI 2 lesions that comes into SLIM CRAB criteria. So 2 criteria must be fulfilled. In addition, if there is an MRI having more than 2 lesions, more than 5 millimeter, then it fulfills the diagnostic. Only MRI is not sufficient.
Yes, that's what I'm asking. Is the renal involvement or failure is reversible in multiple myeloma after treatment?
Yes, sir.
In
most of the cases, the most common cause of renal involvement is cast nephropathy, and there lies the problem with controversy with the nephrologists, because the cast nephropathy, we suggest aggressive hydration as well as myeloma directed therapy, but this says that as there is a renal involvement, you restrict the fluid. So as most of the more than 80% of myeloma is a cast nephropathy, so most of them are reversible if we can treat with hydration or dialysis along with myeloma directed therapy like bortezomib and cyclophosphamide preferably.
Okay. So another thing is, we are frequently finding this, a large group of patients of us cannot provide or access to I mean, better, newer diagnostic modalities, flow cytometry and all these things. They just put on that we cannot go anywhere. With the Shastro Sati, you do the management. Can we at least 1 or 2 cycle with thalidomide and dexamethasone? Should we start as physician in those patients who are really put faith on us that you start the treatment, whatever happens, you start it. Is there any harm or doing this? Yeah.
We are discussing science. We cannot.
Yes. That
talk
is but
otherwise it
but the society is also with the
Yes, but-
science. So that's my question: whether
What
is it possible? Yeah.
we are talking about criteria.
Uh-huh.
what I can suggest is, before starting treatment, get a bone marrow aspiration plus biopsy done.
Yeah.
If a bone marrow biopsy sample is there, later on we can do immunohistochemistry from the biopsy, if
Yes.
it is possible. And under Shastro Sati also, I think these basic investigations can be done. That is immunohistochemistry.
Bone marrow plant. But this is, I don't think, a major discussion.
Okay.
But get a bone marrow biopsy done. মানে একটাই বলা, সেটা হচ্ছে যে please don't do only aspiration. For multiple myeloma, get a bone marrow aspiration plus biopsy done.
That is the okay. I think we had all the questions discussed. Any pending question? Just see.
Yeah, I am Dr. S.B. Ganguly. I will make some comment.
Yes, sir.
First, thank you, Rajib, for your wonderful discussion. Now, multiple myeloma is a disease. To diagnose, you must be multiple myeloma minded. Otherwise, you will miss it. I remember few cases. First, when I was in Arjigarh, father of an intern was admitted under me, resident of North Bengal, with macroglossia. Only his problem is tongue is increasing size day by day. He had anemia and high ASR. After a lot of investigation, at last I do the bone marrow examination and got multiple myeloma. From then I made an algorithm that any patient above 60, if present with anemia and ESR, I will do the bone marrow. 2 years ago, one of my friends in Charnock City referred a case to me, a 70-year-old female with low back pain and with a bone density done, Z-score minus, a clear-cut case of osteoporosis. And I give this osteophos and all things that is in the COVID era. But after 1 year, there is no improvement. Then he again came to me with a pain in the shoulder. Then I heard think anemia, no anemia, hemoglobin 12, no ESR, there is no increase of the albuminous protein, albumin globulin ratio normal. Then he presented with pain in the shoulder. Then I thought that pain at the 2 sides can't be due to osteoporosis. And I admitted him. Then I was in KPC and done the bone marrow and the serum protein electrophoresis. It was a case of multiple myeloma. Now I want to ask the 2 hematologists that hemoglobin normal, ESR normal, albumin globule ratio normal. In this way, how many multiple myeloma they have seen? I was befooled for 1 year because these 3 criteria was normal, and in my algorithm, if these 3 criteria are normal, I used not to think of multiple myeloma. I want to ask Rajib and Madhuchanda.
Yes,
how many
sir.
patients of multiple myeloma they have seen without anemia, without high ESR, and without increase of the non-albuminous protein?
Yes, sir. What I suggest is, in a suspected case of multiple myeloma, suspected case means patient is having some pain not being explained by anything. If you want to do an M protein, please don't do only serum protein electrophoresis. Please do all these 3: serum protein electrophoresis, immunofixation, and SFLC ratio. As Madhuchanda has mentioned, if SFLC ratio is normal, it is very unlikely to be a multiple myeloma if all these three are normal. But often what happens, the serum protein electrophoresis may be normal, or IFP also may be normal, but SFLC ratio is usually abnormal in multiple myeloma, number one. Number two is, in actually non-secondary multiple myeloma, it is a possibility, but that is less than 2% cases. That is in non-secondary multiple myeloma. And often, what happens, bone marrow also not involved, but there is some plasmacytoma in some places. So the pain which you are telling, that can be a localized plasmacytoma. So if there is a localized pain unexplained by some things, by any other means, then we need to do MRI of the lesion to see whether we are in growth or plasmacytoma.
Now, when pain came again appeared in the shoulder girdle, then I thought multiple myeloma. It can't be osteoporosis. So I made an algorithm that if I diagnose, if a patient present with bone pain, osteoporosis should be the last diagnosis, because osteoporosis are generally painless. In an aged female, after 70, we often attribute low back pain to osteoporosis, but this is very, very wrong. Unless there is fracture, osteoporosis are painless.
This can be a simple degenerative disease. The degenerative disease also can present with pain.
Yes. That is the alignment problem. Next thing about which you call that immunofixation is a must. Without immuno, and in this February week of JAPI, Journal of Indian Physical Association, with a sophisticated people neglect this journal and read only NEGM, but this journal is improving very much. They have presented a case of 32-year female presented with low back pain. In immunoelectrophoresis, it was normal, but it was ultimately diagnosed by immunofixation. And their clue was that renal failure with high calcium. So it is also algorithm that if I get a renal failure with high calcium, then I will think multiple myeloma. What about the age of maybe the age baby? And
yes,
this
sir,
female, and this female patient written in the JAPI in the February week only 32 years. So we want to introduce this idea to all our students that renal failure with high calcium. Renal failure patients are generally with low calcium. Think of multiple myeloma. And without immunofixation, you can't exclude multiple myeloma. Thank you.
I just completely agree with you, sir. I just only want to give a comment. That is, renal failure with high calcium, we need to do a 24 hours urinary protein electrophoresis with immunofixation also, in addition to serum protein electrophoresis. Yes.